who to call on if you've got questions at the end of the session. And also, please make sure that you've got yourselves muted. We will have you unmute yourselves when we call on you for questions. Thank you.
Can you hear me? But I feel like it's not going through the headphones. Okay. So as you know, Mary and I can't be trusted with a PowerPoint. But it's up to us tonight to share the PowerPoint. So um, I am going to try. Y'all know by now that I don't know how to really show it in presenter mode and be in. And I apologize because I lean forward into this, and so you're going to see my forehead really closely. Okay.
Are you sharing your screen, Katie?
I'm trying to. Right now, my PowerPoint is like thinking, this computer is like a dinosaur. So every time I try to pull up the window, it's not wanting to share. But here we go. um, there's no subtitles, so I don't know why it's asking me to share. Um, but that could be a me thing. I know, Carrie, you just did that. Oh, and for those who don't know, this is being transcribed and recorded. So we will be sharing that. Um, and then you all seeing my PowerPoint?
Yes.
Okay. So we are going to turn it over to Chelsea, who we're going to go over some RN bargaining unit updates. Chelsea, if you would like to speak about the recent wins we've had legislatively.
Yes, I can do that. Thank you so much, Katie. For those of you who don't know me, my name is Chelsea Bruin. I am the outpatient RN contract specialist. So I help all of the nurses in the outpatient world if you need assistance with various things. Just wanted to talk about a recent update that OFNHP did put out on social media, but in case those of you did not see it, recently in Salem, the legislature had their session. It was a short session this year. And for those of you who work inpatient, you probably have heard of House Bill 2697 that was passed in 2023 that gave us mandated patient ratios in the inpatient world, and also fines for the hospital not having staffing plans approved through their staffing committees. Well, this session in the legislature, there are two sponsors to this bill, House Bill 4074, which basically was an amendment to the current staffing law that we have. And there were two Republican sponsors of this bill. One was Representative McIntyre and the other one was Representative Deal. And they pushed forward in the House Committee on Healthcare to update this with House Bill 4794. And basically the updates would have changed the med-surg ratios to 1:5. It also would have said that if staffing committees are not able to pass staffing plans, that the ratios in the law would end up taking over and constitute a passed staffing plan. So if the staffing committee was unable to agree to a staffing plan for a certain unit, then it would just be whatever the ratio is in the law would be the passed staffing plan for that. And then it also put limits on the fines that hospitals can receive, capping the amount that they can receive, and also would have put a stop to penalties accruing until July 1st of 2030. And one last thing that they were trying to pass with this bill is saying that OHA would accept hospital attestation, if I can say that correctly, as sufficient documentation that they took certain actions. So basically a believe me statement, instead of having to show OHA that they proved that they were able to be in compliance with something. So all of these were wrapped into House Bill 4074. Myself and Mary Kofelt, along with Hannah Winchester, who is the political representative from OFNHP, went down to Salem and we spoke to this committee. There were a lot of other nurses in the room, many representatives from ONA there. We basically made statements saying, yes, this bill is not perfect, but it is working. Please do not change it. We were heard in our statements. So this bill didn't even make it out of that subcommittee to be able to be heard in the whole Oregon House. So yay, win for nurses. But do also want to point out that Art, oh my goodness, why am I having a blank? What's his last name?
Dominguez.
Thank you. I was going to say Hernandez. I'm like, that's not right. Art Dominguez, who is now the regional vice president of nurses in the Northwest, who was also brought to Kaiser to push on the whole magnet status, was there, and he spoke to the legislatures on behalf of Kaiser, and basically had a bunch of numbers that he gave out and said, this is hurting Kaiser, this is hurting patients, we need to stop all these fines, and spoke like he sits in our committees and kind of knows everything that's going on, and that's not exactly the truth. So with that being said, we represented really well, we supported, we were able to stop the bill in its tracks, but also recognize that year after year the Hospital Association, which is a conglomerate of all of the hospitals in Oregon, are probably going to push back and continue to push against the staffing bill. But the fact that we got a big win this time shows that what they have put in place in Oregon is working. So we're happy for that.
Thank you, Chelsea. So I am going to talk about People Pulse and Magnet. And so, unfortunately, I didn't look at the PowerPoint before I wrote my script. So it is a little flipped, but I think you'll know exactly what I'm trying to say. But the first thing I want to talk about, because I think this is fresh in everybody's mind, because for some of us, it's going to hit our bank account tomorrow, and for the rest on Friday. But you may have seen Kaiser's recent leadership message about the Alliance Performance Sharing Program, or PSP. In that message, Kaiser explains, I'm sorry, it's also bedtime, so people aren't happy about that. So I do apologize about background noise. In that message, Kaiser explains that the program wasn't fully funded because the organization did not meet its financial threshold. Before I continue, I want to be clear about something. And what I'm going to say next is my opinion as Katie Johnson, a bargaining unit member, not an official position of OFNHP. But I think it needs to be said out loud. Are nurses being blamed for the strike? Yes, absolutely we are. Do I believe that there are elements of retaliation in how this narrative is being framed? 1,000%. PSP is bargained. So what we are getting paid is what we were agreed to, right? We can't argue with that. But it's how we got there and the rationale that our employer is using. That's what we disagree with. Usually, partners, we get to see this information. We get to see this data. We know what it actually is. And no one's seen it. Usually we get a letter before that says, Katie Johnson, this is how much you're going to get this year. There was no letter. There was no previous announcement. And I believe our membership deserves honesty about it. What we're hearing from leadership is that the organization did not meet its financial thresholds. So let's be clear about what that actually means. PSP is tied to Kaiser's financial performance, not the performance of nurses. Nurses showed up every day. Nurses have cared for patients. Nurses carried the work of the system. And when Kaiser doesn't meet its financial targets, the program isn't fully funded. The financial targets belong to Kaiser, but the patients, the work, that all belongs to nurses. And so this ties directly to People Pulse. When nurses fill out those surveys and talk about staffing, workload, burnout, and the realities of providing care, that's not complaining. The nurses tell the truth about what it takes to care for patients today. People Pulse is supposed to capture a real experience of staff. It's a place for us to have our voice. So for the first time in 12 years, I saw my department's People Pulse results. And what we were told in our UBT was that leadership believed that the scores weren't real because of the timeline. Last People Pulse was in September. And so we purposefully tanked PSP by our responses through the People Pulse. So let's be clear about that. OFNHP never ended partnership. We paused during the 5-day strike for obvious reasons. It doesn't make sense for our non-striking units to participate, like our tax, dental, to protect and participate in bargaining activity or partnership activity when there obviously is no partnership to be had. So the narrative is now that the union's actions somehow explain system failures, and that narrative doesn't hold up. Even during that time, nurses still identified and returned millions of dollars of waste back into that organization. Let me tell you, we saved the organization as an alliance in the Northwest $19 million. And we put that back in. That's because we see waste in every day that we do our work. We know what's wasted. We know what we're facing. And that matters because it proves something important. Nurses understand the system. Nurses know how to improve it. Kaiser had a choice. They chose to let us walk. And we had a choice. We chose to stand up for our members and our patients because nurses across this organization knew something wasn't right. Patients deserve better, nurses deserve better. And the only way left to make that visible was to walk. And that's exactly what we did. We didn't walk because we wanted the conflict. We walked because we ran out of ways to be heard. What we signed up for was a real partnership and a relationship built on trust, honesty, and respect. Not one where nurses raise concerns and those concerns aren't real and they're told that they're not real. And to this day, Kaiser has yet to ask us the most important question: why? Why did healthcare workers feel like there was no other option? Because when people feel heard, they don't walk. When people feel respected, they don't walk. And when nurses believe that patients are receiving the care that they deserve, they don't walk. Isn't it ironic that also they blamed the high utilization? They blamed our patients, the high utilization of care. Well, if I could actually get a timely provider appointment or a dental appointment, perhaps that wouldn't engage the emergencies, which then trigger more complications or hospitalization or a discharge that can't actually be done in 1 to 2 days. But I need a 3 to 5 day stay or longer. So make that make sense. How is it's everybody else's fault but Kaiser's? If leadership truly wants to understand what is happening in this organization, they don't need speculation. They need to look at real data. Look at our People Pulse results. Look at the participation in committees and partnership structures. Look at what nurses are telling you, because those are signals, not noise. And those nurses are asking to be heard. And when nurses speak up about patient care, that's not a problem to manage. That's clinical expertise trying to be heard. If management wants to know what's happening in this organization, they don't need another report. They need to listen to the nurses already telling them. And that brings me to Magnet. Are you all tired of it already? I am. And let me start by saying something very clear. We do believe in Magnet. Magnet represents what nursing should look like at its best. Professional voice, strong leadership, safe staffing, and a culture where nurses can practice at the highest level. But nurses right now don't feel like they're a part of that journey. We need a seat at the table. Not after decisions are made, not in a presentation after the fact, but at the table where those decisions are being shaped. And we've been told Kaiser has invested in this journey and that OFNHP has been invited to participate. But let's be real honest about what many people in this room already know. Our labor partners have voiced they are not the ones meant to represent nurses in this journey. Labor chooses labor. And yet, we're seeing is management selecting labor voices, and those are being included. Because that allows them to say factually that the union was engaged. Technically, that statement is true, but it only tells part of the story. Because engagement is not the same as representation. Engagement is not the same as nurse voice. And engagement is not the same as shared decision making. If Magnet's going to mean something to nurses and to our union, we must have a real seat at the table where that work is happening. Not because it helps the narrative, but because nurses are the ones doing the work every day. And I also want to challenge you with something else. I challenge you to go and watch our regional chief nurse executive, Art Dominguez, testify against safe staffing protections. In the entire state of Oregon, only 3 organizations testified in support of rolling back the protections nurses gained through House Bill 2697. 3. And those organizations that chose to stand on that side of the issue, we should actually look at the quality of those partnerships. Asante, Providence, Kaiser. Because our organization openly testified against safeguards designated to protect nurses and patients, I think it's fair and honest question. How does that align with the Magnet journey? I also want to recognize something else. I had the opportunity to watch Chelsea Bruin and Mary Kofel testify before legislators, and their testimonies brought tears to my eyes. They spoke with honesty, they spoke with courage, and they spoke with the kind of truth.
It is beans. It's red beans. That's what they eat in Japan.
Nicole
candy.
Delaney, can you please mute?
That sounds delicious. And they spoke with the kind of truth that only nurses who stand at the bedside every day can bring into a room. What they spoke about wasn't about politics, it was about nursing excellence. And that is what nursing excellence actually looks like. It's about patience. It's about the dignity every patient deserves in their care. When nurses advocate for safe staffing, they aren't doing it for themselves. They're doing it because they understand what happens when nurses are stretched too thin. They know what it means for the patient in the bed. And that is the heart of this conversation. Magnet is supposed to reflect nursing excellence. And excellence doesn't happen when nurses are simply told the direction. It happens when nurses help set the direction. Because Magnet isn't something leadership achieves. Magnet is something nurses create. Magnet doesn't live in a designation. Magnet lives in the decisions nurses make at the bedside every day. And if Kaiser truly wants Magnet to reflect nursing excellence, then nurses must be partners in the journey, not an audience watching it happen. And if leadership truly wants to understand how nurses are experiencing in this organization, they don't have to look far. They can start with the People Pulse results. And that brings me to our People Pulse are coming this month, March.
Rose, can you mute?
And with that, I'm going to turn it over to you, Mary.
Okay. Thank you. I'm People Pulse is coming, I think next week, correct? It starts next week.
I just know March.
Okay, March. I'm just going to give you a quick update on national because I know that's kind of a hot topic. That's kind of what people are kind of wondering about. And I'm sure you all know that Kaiser has filed a lawsuit stating that they do not need to engage in national bargaining. Backing out now is unlawful since they are currently and actively engaged in bargaining with us. We have filed ULPs jointly with other alliance unions. If we wait for it to go through the legal system, we may be taking months to resolve, and Kaiser would have the right to back out of bargaining in our 2029 contract. The alliance unions are coordinating a solution. We are bargaining with Kaiser on and off the record to find a pathway forward. The goal is to preserve all of our rights and benefits afforded to us through our national agreement and have uniformly across all to make uniformity across all alliance unions. Whatever position Kaiser takes on national bargaining, the right to coordinate how this happens belongs to all of us.
Was that it, Mary?
That's just a brief thing with happening like on national bargaining is
Whole lot of nothing.
I think the to read between and to say things forward, we are actively trying to find a way to make a path forward to keep it out of the legal pathway so we can get our contract done. This is important to all of us. Like we had no idea when we engaged in this contract bargaining that we would be almost 6 months past our contract. So we have to find pathways forward. So on and off the record means that there's things that we can speak about openly, and there's things about that they're just the alliance unions are doing off the record too.
It's like when we were in that weird supposal land. They have ideas. It's more than just ideas, but they can't be codified into any actual record.
That is what they're working on right now. So that's on the record. They are openly working on that. What do we have next, Katie?
Next, we have Jeffrey or Aaron. I don't know where we landed on preceptor language.
Aaron, I believe, for the win.
Yep, I believe that was me. So we did, talking about things that we, get into our actual contract and what our current appendix or our current TA is going to show. This is an area where we did get some big wins. Number one, expanding preceptor pay to all RNs, inpatient and outpatient, at all sites, at all specialties, is a huge win. We did get an increase in the preceptor differential by a little bit, up to 230. And then we expanded that we will get preceptor pay for precepting travelers, as well as all the existing new hires, new orientees, all of that. Was there anything else? Those were the three big wins, right?
That was the three big wins.
Yeah. And I don't believe there were any other significant changes. So yeah, this is an area where we really got big wins, not necessarily everything we wanted as far as the increase in the differential, but getting it expanded out to precepting travelers, getting it expanded to outpatient are really big things for everybody. So really good job on that one.
And I do apologize. You're going to hear a lot from me tonight because it's back to me. So one of the areas that we really worked on is bargaining Article 25. And because, most of our contract had been written in 94 and before. And so we actually had an LOU out there that said that the parties agreed to integrate it in like 2005, and tell me how it never got integrated into our contract before. And for those who don't know, I have been dubbed the savant of LOUs. And so sure enough, is there an LOU that I know that's supposed to be in the contract? We got it in the contract. And so let's really talk about some of the big important things. Okay, we have national, and I'm not really going to talk a lot about national because it is still out there. While we do have a TA that we will be increasing the amount by each year, and the amount of travel and lodging that you can be reimbursed for has also increased. I don't believe that the employer is going to take it away from us. We just don't know how things are going to land out. What the intention of this slide is to really articulate to you all that we have three buckets of money. And I don't think that a lot of people know that. So we have national money, we have OFNHP education funds, and then we have $20,000 of certification funds. And I can say with probably all assurity that I know that people don't know about the money that we have available to us, because even me, I just found out, and maybe I'm slow to the game. I had CEUs reimbursed through national tuition money. I gave them my receipt. I took them and they paid for them. Nothing else needed to be attached. So I just wonder, and it brings me to wonder, because we have over $350,000 in our OFNHP education funds. One, we have not had an active education committee since Meg Tuttle retired in 2021. And if you were to actually apply to this day to the OFNHP fund that you find on HR Connect, it still has her name on it. I have been trying for the last 2 years to get this committee up and running. We actually have names for people who are still, bless them, willing to serve on this committee. They're just waiting. And so we have management now willing to not only invest more money into it, because in Article 25, we currently get $44,000. As it should be, as we came to learn, I had the opportunity to sit down with Meg Tuttle and look at historical documents that never made it into our contract. The $44,000 was original money. And the intention of that fund was, as we grew, that fund grew. That never happened. And really, if we had it for one-to-one for the amount of nurses that we have now, which is about 2,600, we should have over $1 million into that fund each year. That simply, we're not using it. We have, like I said, $350,000 in this fund, but because there's no oversight. And so people apply to it, and as long as you're under $400, you're going to get it. But who dictates how that money is spent? Well, the education fund committee members. And so we reinvigorated that in our language. We also have certification fund money, which is different from our education fund. It's the same form on HR Connect, the same form that has Meg Tuttle's name on it. But we have $20,000, and we had an LOU that said for the last 20 years, this was going to be in our contract. Tell me why it was such a fight to get this money that's already counted for. We agreed to put it into our contract in our actual contract. So your education fund is very important, because once you've used your national money, say you're in college, you're getting your BSN, you're getting your MSN, you're getting social work, whatever. Once you use that $3,000, you go then and tap into your education fund. Once that's tapped in, that is done. You're out of money for whatever, unless you're using some kind of program through Ben Hudnall or whatever. But say that same year, you also decide to become a certified nurse. It's not required for your job. It's just a desire that you've wanted to do. You're going above and beyond. You don't have to pay for it. You do have to get reimbursed for it, but you don't have to pay for it. So you have the ability to put forward in the OFNHP fund, and there's another bucket of money to access. One of our major wins is that in our education fund, and I'll show you in our next screen, is that if you're like me or Mary Kofelt, which Mary Kofelt is much of a head scratcher to me, because she's a Sunnyside nurse. She's a labor and delivery nurse. Tell me why she is required by her job to hold a Washington license. She doesn't practice in Washington. She doesn't pick up a phone, but there's a possibility she could one day pick up a phone, which requires her to not only have an Oregon license, it requires her to have a Washington license, which means you're bound to all of the laws and stipulations that Washington has. So we carry a lot of liability that the employer doesn't pay for. So I am a Washington nurse. I am a direct line nurse. I don't pick up the phone. I don't give phone advice, but I have the opportunity that I could possibly pick up the phone, and the patient could be in Oregon, and therefore I also have to have an Oregon license. My Washington license is my professional responsibility because I live in the state of Washington. I practice in the state of Washington. Kaiser says that I have to have an Oregon license. I'm sure it's some kind of Medicare or some rule or insurance thing. Why do I have to pay for it? Now I don't. Oops, sorry. So now, continuing education programs, this is for national tuition reimbursement or your OAF and HP education funds. So number 1, 2, 3, and 4, all the same. We didn't change that. We improved some of the writing, but the language is essentially the same. Number 5 is what's new. It's to defray the cost of a secondary state licensure if it's required by the employer. So if you are an Oregon nurse and you're required to have a Washington license, you can now submit and get that reimbursed. So this is the bigger thing. So we all have educational leave if you are benefited. Even now, which we haven't gone over, is Article 8, where Article 8 is our employee definitions. Benefited on-calls now get education leave. And so in that, I have had the opportunity to attend things that are sponsored by Kaiser, but yet they said, well, you can't use your education leave for that, and you can't use your money for it, but it is partnership training, and to name it specifically, it's the Alliance Leadership Conference. And I acquire new skills. I update basic knowledge, change attitudes and values. It's for the brief moment I believe that, partnership can actually happen. I can implement new concepts of change throughout my practice that I could bring back as a team lead in my department. I don't get CEUs for that. I go to these classes, I learn about partnership, I learn about things that will make me emotional intelligence, things that make me a better nurse, a better colleague, a better leader, yet I can't get credit for it. So we have other programs that are very beneficial that you can say it applies to 1 through 9, but yet there's no continuing education, you can't get it. Management heard us, they agreed with us. It no longer actually has to give you continuing CEUs. Now, if you're doing online education, that's a different story. You still have to provide CEUs for that. But if you're going to a conference or something and it meets any of this combination 1 through 9, you can get it reimbursed. So that is, in my opinion, a big win for us. And somehow my slide got a little messed up, but it's okay. We're going to transition a little bit into PNAP. It's not as early as I want. It's a little too soon, but we'll talk about it and then transition back into education because it's all the same. So as you may have heard, Career Ladder is going away. As we know it, it has served a lot of us well. It has contributed a lot to our organization and to us as nurses, but it's not evidence-based built. Rachel Scholes and I, the ONA chair, as you all know, I obtained my master's in nursing leadership and management, and one of the guiding things was I created part of my thesis off of a professional nurse advancement program. I have seen it at other organizations. In fact, my first hospital that I went to had this. And so we will be sunsetting the Career Ladder. And I'm sorry, this is a very busy slide. I should have rethought that. The new language will no longer be an appendix. It will be in Article 15 because it is part of compensation. We will be moving to the RN, Professional Nurse Advancement Program. And because Kaiser likes everything with acronyms, it's called PNAP. The way that we built this is that it could be then built into like the professional or the tech bargaining unit. They could build some of this and have their own career letters. So the employer and the union recognize the importance of professional nurse development, clinical expertise, and leadership amongst RNs. And to support this, they agreed to support a program for OFNHP and a new committee. So what is important is we got language in our contract that says that it's available to all bargaining members. And it is not conditional. So it can't be taken away from you because you're on a level or a corrective action. So no RN shall be denied participation in this program. We got contract language that the program shall be reviewed annually with the employer and the union from the committee's recommendation to ensure criteria remains fair, relevant, and equitable. An advancement on this is based off of evidence, professional practice, education, leadership, certification, criteria mutually determined by the union and the employer. The career ladder as is, and I have to give props to our chairs and the committees and our reviewers. They are unsung heroes. They do a lot of it on their own time. They're supposed to be getting release and support and guidance that I don't believe that they actually get. But the problem is it's not contractual. And so we got it in the contract so that their work is honored and recognized because we updated the language in Article 6. And while this is a contractual, this is a framework that we're building. So this is the agreement of our task force because it will take time for us to build the program and then transition. Some people might get grandfathered in, or we're going to be everyone will be starting on a new level in here. And so how that works is going to take some time. And it will be committee members. It will have who will be building the program, building a charter, and doing all of that. What's important about this letter of agreement is that there is a time frame, and I'll show you that in the next maybe not in this next slide, but there's a time frame. I think I had to do 3 screenshots. We got codified in contract that we already have money that's invested into Career Ladder. We're not losing that. We're gaining $2.5 million. So currently, Career Ladder, and this is why it's very, very important to get your engagement in. Career Ladder is about $4 million program right now. Soon it will be a $6.5 million program. And it is meant to really recognize the work that we do. These programs need to recognize our contributions to the profession. Like I said, the first hospital that I worked at had a similar program. And I was a clinical nurse 1 as a new grad. And that designation was displayed right on my badge. And so it helped other staff know, hey, she's probably not the one, she's a new grad, or she's the one, pull her because she needs to see this. And it wasn't something that I would have to say, hey, I'm a new grad. I don't know what you're having me do or what you're asking of me. My colleagues knew right off the bat. I mean, I'm sure it was obvious. I was in the new grad program. I was with a preceptor for a very long time. But then, people forget. People come and go. But they knew exactly what my professional journey was at that time without me having to be in an awkward situation or them being in a situation. And so either I was welcomed with like open arms of mentors, and they were very encouraging, and they pulled me for experience and just everything. And so it created collaboration and support and a connection within our team. And so after my first year, my badge got updated and I was a clinical nurse too. So this told everyone, okay, she's not new. She knows a little bit. And it was up to me at that point to become engaged. And many of those mentors that built me as a nurse are still in my life today. And I do think that that's part of the journey that PNAP is supposed to build, is mentorship. And, the designation said something important. It shows that you have experience, you have knowledge, and you're growing in your profession. And I remember meeting nurses who were clinical nurse 5, nurses who were actively working and lobbying for healthcare improvements, and they were inspiring. And I remember thinking that I wanted to be a nurse like that one day. And that's the power of recognition programs. They just don't acknowledge what we have now as a career ladder. They don't acknowledge the work that the nurses do. And we want to inspire nurses to grow. And that's why it is disappointing that we don't talk about career ladders. Nurses should be proud of the work that they do. Just please give me time. Okay? Not much. Sorry. And nurses deserve to be recognized for the growth and their expertise every day. And so that's why we put forward the PNAP. And it was promptly dismissed by Kaiser. And then somehow in December, Kaiser wanted it to come back. And they said not only did they want this program, they needed it. And they were willing to invest money into it. And that piece might seem small, but it's actually really important. And that's why we put it in Article 15. And so, like I said, it establishes that there will be a professional advancement program. Nurses cannot be withheld from participating. And if changes need to be made, nurses have a seat at the table. And that's really important because this is not a labor management partnership work. This is bargaining work. And this is language that protects nurses and ensures that the program exists and involves with nursing input. And so going back to Article 25, and I do apologize that I did not catch that my slides were not in order. If you were to go into the contract right now, you'll see that certain departments and even departments that don't exist anymore and haven't existed in a long time, we have ACLS, NRP, and PALS that are called out. However, the practice is we get paid to attend our BLS class. We should be paid to take your NIS. And what is most near and dear to my heart, and Kaiser's big middle finger to you, Katie Johnson, is what held us from getting a tentative agreement was they absolutely refused to put ONS in there. Every 2 years, I have to renew my oncology provider card in order to administer chemotherapy. I cannot administer chemotherapy without that card, just like I can't do BLS without that card. They'll pay for BLS, but they won't recognize ONS. Make it fair. Well, not fair, because fair is different in everyone's mind, but make it equitable. Why do I have to take my education leave when it's a requirement that you need? Why do I have to fight an employer to pay for the class that you require for my employment? And so we have it codified into contract. If the employer requires it, and it is a condition of your employment, they pay for it. Now we reflect and we acknowledge that this list could change. Things might be called something different. We did try to future-proof it as much as possible, but the intent is to capture, if it's required for your job, you get a thing from LCR. You don't have to fight to get it, and you don't have to use time unless you choose to. Some people do choose to use their education day for this. And with that brings us to seniority. I think the big shebang, why quite a few of you are here. And so I wanted to take a few moments to talk about the discussion that has already happened around seniority. Many of you have already seen the language during the redlining process that generated a lot of reaction. And before we go any further, I need to address and clarify again that what you saw that got so many people upset was a working draft. During bargaining, we redline language as part of the negotiation process. Early versions of the language are meant to be reviewed, challenged, and improved on before it becomes final contract. That's how contracts get stronger. So the language that circulated early in the process was never presented to you as final language. And it was always understood that it would continue to evolve as the bargaining team refined it. And so some of these things you already know and has not changed whatsoever. Our old language was antiquated. It did not make sense. It relied on the employer to give us accurate factual data that you can't track. You really can't. And if you add 882 by 2, it's not 1664. It's just capped, right? And so who gets what hours and what gets added, we don't know. We can't trust HR Connect. And every 6 months, I get bombarded with emails. My seniority is not correct. I've been taken off. My numbers haven't been right. The amount of audits that I've had to do on my own seniority is insane. It's just because I am aware that I know to look for it. Now, I want to be clear. Did the seniority language of us going to a date of hire, does that... the intent of that was having a system that is uniformed across OAF and HP. We were one of the few bargaining units that don't use it. We're one of the few that have issues. And guess what? It's not national that tells you what your seniority is. It is someone sitting at a desk who has to manually calculate that. Do they have to prove their work? No. So why are we relying on a broken system? So what we've always proposed is moving to a date of hire into an OAF and HP represented position. It is maintained for 90 days. It is unfortunate that we had to put this into the contract, but we did. And we put in protections should a member be held or detained by ICE, that their seniority is protected. And it's trackable and more accurate. Either you know you were hired on this date or you don't know that you were hired on this date. And that's pretty easy to fact check. So rapid shuffle doesn't change. We have gone over it. I'm going to just move on to what has been the meat and the potatoes of this conversation. Out of arena shifts is defined in seniority. So we know if someone is out of the department, they don't have priority over someone in the home department. And that is an important piece because that has a lot of grievances as it is. So this is the biggest thing. What we've always been consistent about is the intent behind the language. The intent was never to weaken seniority. The intent has always been centered on something fundamental in healthcare, ensuring that the right nurse is caring for the right patient. Healthcare today is very different than it was even 10 or 15 years ago. Nursing practice has become increasingly specialized. Nurses now practice in areas that require specific competencies, certifications, and experience. And because of that, we have to acknowledge a reality of modern nursing practice. A nurse is not a nurse, is a nurse. We all say that all the time. A nurse is not interchangeable with another nurse. An oncology nurse practices differently than an ICU nurse. It's true. A procedural nurse practices differently than a clinic nurse. A research nurse practices differently than a bedside nurse. These are different specialties requiring different competencies, and those competencies directly affect patient safety. And I want to be very clear about something. Patient safety can't be determined by seniority alone, period. Experience matters, seniority matters, but competency within a clinical specialty matters as well. And that is the reality of modern healthcare. And I want to say something else about seniority. The most powerful thing about senior nurses have never just been about how long that they're here. It's about the knowledge, the judgment, and the expertise they bring to the profession. That experience is what mentors newer nurses, strengthen teams, and improve patient care. Seniority at its best is not just about time served, it's about the depth of expertise that comes with it. And that expertise is exactly what recognizing specialty training and competency matters. It is important to understand that the concept of being discussed here is not new to our contract. The current contract language is here. And guess what? Guess who right now gets to determine who is the most qualified nurse? Management. That's not okay. Because I have watched them go through their decision making and decide another nurse was more competent because they actually liked that nurse. Could I prove it? No. But what we said was we have seen this system fail us time and time again through grievances, and the pros actually have an arbitration on this very similar concept going forward. And we said we can't allow that anymore. We can't have management determining who is actually the right person for this position. So we defined qualified. Qualified is now dictated by our contract, should it pass. And so management, like I said, has always had the authority to determine another nurse is qualified for a particular role or assignment, including the fact that they don't like someone. Does that rub you wrong? Because it should. So when we talk about what the bargaining team actually did during negotiations, it's important to be clear about that. We did not create management authority. The authority existed, and so we fixed it. And so we took language that was vague and we cleaned it up. And instead of leaving the definition of qualified open to interpretation, we worked to define what qualified means. In other words, we set the standard. That matters because when qualifications are undefined, management has broad discretion. And if you don't believe that, I would challenge you to ask for grievances that have been filed on positions that have been wrongfully awarded. By defining qualifications in the contract, we made clearer guardrails and transparency about those determinations are made. And I want members to understand something important as you evaluate this contract. If this contract was to be voted down because of a concern related to seniority, that decision would not remove management's authority to determine qualification. That authority already exists in the current agreement, and that contract, our contract, now establishes clearer standards about what qualified means and standards that nurses help define. So when you evaluate this section and you are determining what actually changed, we didn't create a new concept. We clarified language that existed, we strengthened it, and we defined it. Because the conversation around this topic has become heated, and it's really important to remember what this is about. Our responsibility of nurses as a union, as leaders, is not to protect ourselves. It's to protect the integrity of our profession and the safety of our patients. Nursing today is highly specialized. The therapies we deliver, the technologies we use, and the complexity of patients we care for require expertise that did not exist even a generation ago. Our contract has to reflect that reality. Protecting seniority remains important, and it continues to be protected in this agreement. But professional nursing practice also requires recognizing specialty training, competency, and expertise, and that's what's dictated by law. And because at the bedside, the question cannot simply be who has been here the longest. The question must be who has the training, the competency, the expertise to safely care for the patient in front of them. That's the standard we brought to the bargaining table, and that's the standard we defended. And that is the responsibility of professional nurses. That brings us to our next town hall. Our next town hall, we will be going over Article 14, which is staffing. Article 15, money, compensation, and Article 19, holidays. Before I turn it over, I just want to really encourage you all. Please, it is election season within our union. It is very important that you participate and you cast your vote. We don't get a lot of participation in elections, and that's very disappointing. But I can tell you that the position that is being contested, vice president, is very important. And we need the right person doing the right job. And so please, I urge you, read the bios and vote. And with that, I'm going to turn it over for closing and questions. And I'm going to stop sharing my screen. Thank you.
Yeah, we recognize that we dropped. Oh, here we go. Right off the bat here, Brandy Nelson. What do you got for us? How can we help?
I don't have a question necessarily. I just wanted to put this out there. We have a current vote of no confidence in our leadership in the ASCs, and I just wanted anyone that works at Skyliner Interstate and hasn't voted or doesn't know about it to get the word out that that is currently going on.
Thank you. Spread the word. Open for questions now. If you have a question, please raise your hand. Or if you need a clarification, we're happy to go into just make sure everyone's questions are answered and that you have an understanding on what we presented today. And if you can't speak, you can put it in the chat and we'll try to answer it there. But we'll stay on as long as we need to. So any questions? Concerns?
So I see one, I see it in the chat. So I saw, when is the next town hall? Good question. We are hoping for some more information, but the bargaining team, we need to get back together because we are working through redlining and writing some contract language. So we will get that out. Trey, from an inpatient RN perspective, if you weren't qualified for the job you're in, you wouldn't be working that. Oh, no, the chat moved. Dang it. Something about basically you wouldn't have that job. That's not true. We have fellowships. We have internships. We have, I don't know what the real law is now. We decided we're not calling them interns. We're calling them fellowships. So these words to me are interchangeable. But we now have grown pathways for nurses. We have critical care. We have NICU. We have labor and delivery. We have surgical services, all that have internships. And so you can put me in one of those positions. Yeah, I'm qualified. But do you know what? I guarantee you want Jamie Dobbs at that bedside, not me. Yeah, but no. there will be situations as we have more internships and things that yes, you're qualified because all I have to do is have a nurse license for 9 months. I've had a nurse license for over 120 something months. I can get any basic RN job. Doesn't mean that I'm not the right person for it, and it certainly doesn't mean that I should trump somebody else. So,
We have a hand up from Shamsi.
Yeah.
Shamsi, what do you got? And welcome back, because I think you were out of town hopefully on vacation or something.
I was out of town and I got sick while I was out, so I might
Awesome.
start.
Boo.
Yeah, I know. Every time I take a vacation, I don't know. I'm pretty happy with the tentative agreement, and I appreciate all of your guys' hard work so much and all of the town halls and explanations. But I think the question I've been getting asked the most is where do we go from here? Like what about national? Like, are they actually meeting and talking, or are they still trying to divide us?
I think that is a very valid point. Where are we? What is going on? I can tell you that our president is currently in Pasadena. I will need you to connect some of the dots yourself. There are conversations happening. Is my biggest fear that we're going to be one of those people sitting around like 3 years later. We're going to be that meme. It's been 84 years and we don't have a contract. I don't want to be those people. There are conversations that are happening. There are pathways forward. We have been trying to plan A, B, C, D, E. To be honest, I don't know what plan we're on, but I can say that we are moving forward. I don't believe we're going to be in this position that much longer. We just have to hold on.
Okay, so I'm sorry, but
that's a non-answer. I know.
I mean, are we willing to split? I mean, I'm not willing to split. I feel like we have more power as an alliance than we do individually, but do we vote on that part? I
don't think that it's OVNHP has no intention of leaving the alliance. We have no intention of breaking the alliance. We are responsible for the alliance. That doesn't stop other unions from deciding what they want to do. Our number one goal and our number one intention is to remain solid and remain an active alliance. And that's the first and foremost. I think it's asinine that Kaiser, we talked to Kathy Smith, who is the godmother of partnership and the coalition. And it is asinine to think that management wants to bargain with 59 tables. It was a crap show in the 90s. I think we all know that they tried to sue the coalition 2 years ago. They didn't win. They're doing the same tactics. It's scare tactics. It's division. It's just classic. I guess what our employer is union busting, and we're not going to allow for it.
Yeah, the main thing is that they're coordinating efforts to join, to stay together as a collective union, as collectively as unions, moving together those efforts, and that is still happening.
Okay, thank you.
iPhone 7. And first, can you tell us maybe who you are, where you work?
I
iPhone
had
7.
Katie put the qualified language back up because I think that there were some questions people didn't see this slide, and it's right here. So there you go.
So one more time, iPhone 7. You are the first hand up. I don't know who you are because your name's hasn't been changed on your phone.
I'm
Go
sorry, I'm
for it.
trying to get the volume turned back on.
No,
Oh,
no,
great.
no, it's all good.
Can you hear me?
We can hear you. Who are you
Oh,
and where do you
okay.
work?
Sorry. Sorry, this is Rebecca Van Dam. I work in the MedSurg ICU.
Awesome. Welcome.
I just had a question about the language. There's just been rumors going on around how the seniority works as like a OFNHP seniority versus just your unit seniority. And so one of the emails came out with some of the wording that said permanent reduction in position or hours shall take place utilizing reverse seniority by patient care area worked. So I've been a Kaiser nurse for 25 years, 23 years in OFNHP, the whole time in critical care. So if I were to transfer out of the critical care and the other department then goes through a RIF, is my 23 years still going to count for my seniority of if I get RIFed first or last, or only my seniority in that work area?
It would kind of depend on what work area you were going into and where you were at. And yeah, if you were qualified, you are done with your reorientation and your skills are up to date, it would be that you are qualified in that position. So it all kind of depends on where the timing of things are. We'll say that every RIF is something that's bargained, where that's something that's kind of like negotiated, hashed out with labor, and so we have we're very involved in that process. So unfortunately, there isn't a cookie cutter answer of what that would be. I hear the concern, recognize the concern that's there, but it goes off of the where you are in your transition into whatever role it is. With your med-surg ICU, let's say you went into med-surg, you would be, way qualified, like absolutely. But let's say you went into, I don't know, became the lactation consultant or something, like that would be a different thing where maybe some of the skills that you had didn't necessarily transfer over. So it's a case by case thing.
So as long as you're qualified, your entire union seniority would count, not only the years in that department.
Yes, right?
Okay.
Katie, Mary,
Wait,
no?
wait, what's the question? I stopped. I was like, wait, what?
As long as
I was unmuted. I'm sorry.
Yeah, as long as you are qualified, and let's say you got 23 years experience in med-surg ICU, you transfer to lactation consultant. You have completed your preceptorship or orientation onboarding. You are now qualified, that your time with Kaiser would kick in versus
Yeah, it's your KP seniority stays with you. It's everywhere. Like the only thing we're speaking about is our RIF language, and that is what we're speaking to. And so that is what we're talking about, keeping qualified people there doing the work. We're not talking about your everyday, like doing your scheduling and stuff. That's completely something
Right.
completely
No, I'm not
different.
worried about my scheduling. I'm just
She wasn't talking about that.
in critical care for 23 years. I'm not going to stay here forever. So let's
Sure.
say now I go transfer to RAN, and I've only been in RAN for 3 years. So by then that'll be 26 years at Kaiser.
You're more than qualified.
I'd be qualified. But the current language, as I read it, says the RIF will take place utilizing reverse seniority by patient care area.
No,
so I would essentially only be in that area.
That's
No.
the current language.
You're looking at the red line, like the draft.
The most recent email that was sent out that had the copy of the TA was.
Yeah, a more senior RN may be laid off out of seniority if they are not qualified to perform the work.
Okay.
So qualified is defined. So like you just said,
Right,
you
yeah, that's fine. I get the qualified thing. I just didn't understand if even once you were qualified, if it would be your union seniority or only that department seniority.
no, it would be all seniority.
Okay,
For
that's
your
what I was
23
curious.
years. Yeah.
Okay, perfect. Thank you so much.
Yeah.
Good question. Joshua?
Is that Joshua Holt?
Sorry. Hey everyone, Joshua Holt. Katie, I know, of course, the answer to this, but I saw it in the chat. I get asked by every single person that I talk to when I am rounding in the hospitals. And so I'm going to ask you, are we still fighting for retro?
Hell yeah.
Yes. Yes.
I need Botox money.
So, of course, yes, we are still fighting for retro. And I want everybody on this call to know, as a member of your national bargaining team, union leadership, retro pay is going to be the very last thing that is settled. Kaiser is going to say no. We're going to say yes. It is going to be the very last issue that is settled. We are not taking it off the table until we have an agreement to present to you. And hopefully not ever, but it is on the table.
I mean, to be honest, and I have said this 1,000 times, I know you're tired of hearing me say it. I do not imagine, I mean, okay, I don't, say Kaiser says no. I mean, we do have to get off of this trajectory. I do not see it passing. I would be shocked if the membership would actually pass it without retro, but that is their right, and you know they have to have a voice. Do I want to get off of this perpetual, like, whatever hell we're in? Yeah, but I don't see our contract ratifying without retro. And, you know, I've said it a million times. You know, we would have to evaluate where we're at.
The fight continues.
The fight continues, but I also have to say, like, it just angers me. Like I said, I know that we bargained PSP. Okay, I knew, like, the number is the number because we didn't meet the financial gate. The secrecy, that's bullshit. It's a big middle finger to you. And the fact that the scabs were paid what was it, an inconvenience bonus that was bigger than our PSP. You can't tell me that that's not like a big FU to those of us who have invested blood, sweat, and tears into this organization, and who believe in this organization. So I find it highly disrespectful. I believe they'll try, and they'll try. You know, I have heard from colleagues that you know, it's rumored that that's why it's all secret, because they want to then say we can't even afford to pay you retro, yet they've already put away $9 billion more.
Do we have any other questions?
Michelle
Hi, this is
Jacobs,
Michelle
are you
Jacobs.
on? Oh, okay, perfect.
Yes. I figured there was a little bit of a lull, so I just jumped on because I can't raise my hand.
Yeah, no, you're good.
Language. I put it in the chat. So qualified means all qualifications plus preferred, and as we know, Kaiser's job descriptions say you're preferred to have a BSN. So with that being said, say you have a nurse who comes from Providence doing the same job on a med-surg floor, and they're just as qualified, but they have a BSN, and you have a 20-year nurse who's been with Kaiser for 20 years, qualified, but they now have associate's degree. Do they get riffed first?
No.
No, and we bargained specific that that's written into the contract because we didn't want that to happen. As someone who spent their majority of their career so far as an associate degree nurse, it doesn't make someone better than you just because they have a BSN. And so, education as the preferred qualification shall not be considered grounds in or disqualification or used in a manner that disadvantages the applicant in any kind of process. So we specifically
Amazing.
wrote that in.
Thank you so much, you all.
Yeah.
William Baldwin. Is your middle name Rutherford? William Rutherford Baldwin. What you got, my friend?
I have to allow some mystery, otherwise you wouldn't be coming back for more.
It will forever be Rutherford.
So the PSP is a very hot button issue because we literally just had UBT today and we went through all the numbers and I said, oh, look, we've met threshold, we've met target, here's the things, we should expect this. So very frustrating to find out about this. I know somebody, I don't remember if it was in chat or on screen, had mentioned that if they're going to pull this stunt with PSP, should we even be engaging as UBT? And I'm a little split on this. And I'm asking for guidance because as the UBT co-lead, like, I'm fine burning it to the ground. But I also know that anything that we don't engage through UBT, they will just make a management directive. So I'm kind of like,
You're in a hard position.
I seek your guidance on how many fires I get to set.
Officially, we don't have a position. I can't speak on behalf of OFNHP. I can speak out of what I believe. And I don't think we position ourselves in a way that takes away our voice. So many changes get changed at UBT. Now, if we come back and, things could change, especially in your department when your manager has a functional UBT and an engaged co-lead and then sends like directives through email and forgets that they even have that pathway. I struggle to say that we, walk away from it right now when it is our only pathway for a voice. And I saw Rachel with her hand up, and she might be speaking as a labor partner. She might have an opinion.
I have an opinion. And you're right. I did put it down because I was like, oh, Joshua's also on here, and I guess he could speak to it also. But currently, we are not pausing partnership, Billy, for all the reasons that you just listed, right? It is our only path. It is the only way that we actually have a voice at the table is to push initiatives through UBT. I also am struggling with members of UBTs that I sponsor at Sunnyside and the ASCs to see, the members are asking the exact question you are. So I don't think that you're in a unique position to be thinking this. I think it's in the forefront of everybody's mind. But I do want everybody to know here that the financial gate is not bargained. That is not something that unfortunately we get to have a say in. We did at one point try to have a say in the financial gate, but we grieved it and we lost that grievance, unfortunately. So, the arbitrator said, nope, it's Kaiser's business. Kaiser gets to set their financial gate, their operating margin, so on and so forth. Okay. But, if you remember last year, the Alliance did have to go to fight to Kaiser to say, hey, look, we met X amount of money, we saved X amount of money for you last year. I don't know if that can happen this year just because we're in a very different position with the continuation of national bargaining. But I do want to put it on the radar that you're not in a unique position. Again, everybody's thinking the same thing. OFNHP has not paused partnership, so officially we can't say we are not going to show up to UBT. That would be something that would have to be officially announced by OFNHP. But until then, what we can do is show up and push initiatives that are in the forefront of our minds, and which is going to drive our PSP for next year, hopefully, and just keep on working until we're told otherwise. But that's I don't think I'm telling you anything new, but I did want to speak up about the UBT work, because we don't really, unfortunately, have the authority to say pause partnership. It's not something we can do. So thank you.
There are things that we can do. Sorry. Was that you, Jeffrey?
Mm-mm.
No. Oh,
No.
So there are some things, and I was trying to catch up in the chat, but every time I start getting down some, then it's 102 new messages, or 192. There are things that we can do. Like I said at the beginning, Magnet is being forced down our throats. It's not being, done collaboratively. We've reached out to Art on more than one occasion to say, please let us have a seat at the table. Let us hear this. Does anybody else, if you can, raise your hands, throw it up there in the participations. Anybody have that new board in their department? That's the dry erase one. Anyone else has sat through their manager not knowing how to actually use said board? My manager literally brought the PowerPoint and was going over it, and then she's like, well, I'm a little confused, and then she came back and erased everything because she was supposed to go and get more training. And I said, it's almost as if labor should have also been at this training. Maybe we could have done it together. And she goes, Katie, we have this board that supposedly is showing that we're working together and we're doing all these things. There's going to be a survey specific to Magnet coming around. Is our position don't participate in it? I don't know. Maybe is our position to tell them exactly how we feel? Maybe. I'm not sure, but you can't have nursing excellence without nursing. And if they're not engaging us and they're not asking, but they're setting up all these things, and yet we're just asking to have a seat on the bus, and they're like, nah, you can hold on to the bumper while we drive. So, those are things I think if your manager is pushing you to help fill out this board, no, I don't know what this board means. I need to be trained. I deserve to be trained. That's part of partnership. It's either with us or without us.
If any of the management-driven projects all of a sudden aren't reaching consensus, that's still engaged, right?
That's interesting because I am seeing a lot of projects that are management said, like I said in the beginning, never seen my people post before in 12 years. All of a sudden we got it. And then we were told that we needed to give feedback on 3 specific areas that we were going to fix. And yet somehow all of our UBT projects are now on communication and all this other stuff. But the ones that matter to us about what impacts our day-to-day work, yes, will communication help? Yes. But is it really the priority? I don't know. So it is strange to me, and perhaps you all might be seeing the patterns. Soon you're going to see an OFNHP survey. And we're going to collect our own data, and we're going to go to the American Nurse Association, who controls Magnet, and we're going to give them the real data. We're going to give them the ADOs. I sent them Art's testimony to legislation because they need to know what our organization is actually actively fighting against. I personally wrote Magnet at ANA, and I said, hello. If Kaiser is going down this and we can't even apply yet, there are big problems. They're suing us. We had an active ULP strike. You can't have a ULP strike and be magnet. Both can't be true. So the fact that they won and they chose now for the journey is really funny. When we don't have a contract, we don't have retro, we don't have a voice, all of these things. But Billy, I think you're very smart and capable, and I think you will find a way to continue to push the voice of what your department truly needs. And it might not be easy, and Jeffrey and Joshua will be there for you. But if you're seeing projects that are somehow only ones that management cares about, that is suspicious.
We are not trying to not answer questions. If you dropped a question in the chat and it didn't get answered, probably just didn't see it, not intentional. So if you want to speak up and just flag it for us right now, we're happy to answer it. I saw a couple of hands that went up and then went down. Anyone? I think if there's no more questions, probably...
I should have showed the slide that had our emails on it. Maybe I should do that now, because if you don't see your questions answered, we will be transcribing. We have this recorded. We'll get this out. Here is our information. If you need to email us, please do so. If you don't know who it needs to go to, send it to itsmyunion@ofnhp.org. Soon, next month, Jeffrey will be officially our new vice chair. Send him all your emails.
Cool, I'll just auto forward them to you.
What is it? Assign new role?
Yeah. Anyone else? Questions, concerns? You got all of our ears. We just want to make sure that, closing any gaps that are there. SJ Lee. Yeah.
Sorry, I had a question. Before we were collecting data on positions and stuff they didn't fill, are we still doing that?
Yes.
Because my manager just left, and he gave me a nice little email of all the positions that weren't filled and why. And so in a nice little email. So I didn't know if you wanted that.
Sure.
Yeah,
absolutely.
We would love that.
Yeah.
I don't know if you guys know this, but Katie Johnson is the queen of receipts. You can ask her a question, and she's like, "Oh yeah, I have a screenshot from an email from 1989 when emails first came out." So that we could just put that in the agreement.
I couldn't see in 1989.
Hi,
SJ Lee.
Yes. So I feel like when we did the 5-day strike, Kaiser laughed, said, hold my beer. And then it was kind of ended up being a joke. And then, there's talk I'm trying to understand the importance of being in an alliance when we didn't join UNAC when they walked out.
Well, it's important to tell your members when actions are going to actually happen. So If you don't know about it, you can't participate in it. So it's a two-way street. And no disrespect to our membership or our alliance, but we are in a partnership, and it was really important. I spent a lot of time and effort trying to build a relationship with Peter Sidhu, Charmaine, who are the president and vice president of UNAC. Mary and I had the opportunity, and Rachel, I think. I don't actually remember you, Rachel, if you were there. So, but we were intentional about saying, we're here for you. If you walk out, we walk out, vice versa. And all it required was a call and coordination.
Okay, so it wasn't anything on our end. You're saying that they did not initiate asking us to join them.
Well, they did, and we asked for time, and they said no.
Okay.
So you can do with it as you want, and this will probably go public, but that is what has happened. They reached out to us. We said, give us a month because we needed time. Our membership wasn't there. We all were coming down, and they said no. And then they dropped a notice without telling us.
Yeah,
You don't do
I mean,
the nurse.
the retro pay thing is just, I feel like it's a non-negotiable, because the next time the contract comes up, there's no incentive for Kaiser to come to the table to do anything. This is all to their benefit. So it's, of course, hindsight is 2020, but I feel like, not enough of us, and I mean all the members, are not doing the hard things. Like, maybe we should have gone on an open-ended strike, and it would have been painful.
No,
But,
we shouldn't have gone on an
there's no
open-ended
way
strike.
that, Kaiser would have, just said, oh, whatever, we'll come when we feel like it.
Well, I mean, there needs to be strategy and there needs to be truth. And I stand by saying that it was not the right time. Because guess what? Look at the receipts of what has happened with UNAC. We've been studying Kaiser. Our 5 days did make a difference. It cost them $600 million. Just in the Pacific Northwest. What we did was meaningful. We got them back to the table. We weren't having conversations. We weren't discussing. We weren't having anything. So none of that could have happened, and we wouldn't have reached a tentative agreement in December had we not struck. We did it in the right time, in the right place. But we also are mindful and wise and looking at things. And, each union in the alliance has the authority and the autonomy to do what they believe is right. And it's not ever going to be at the risk of our OFNHP members. It's not going to be at our livelihood. And it's not going to be without a plan. There may be a day still that comes that we say we do need to make that step. I don't know. But the one thing that we're not going to do is we're not going to mislead you, and I have to work side by side with you all. I don't do this for a living. Mary doesn't do this for a living. Jeffrey doesn't do this for a living. We work shoulder to shoulder with you all. We are all frontline nurses, and we have built a lot. Like, OFNHP has grown as an organization, and one of the biggest things is being accountable, and that means being accountable to not only our membership but who we are as an alliance. And so
I understand that, but do we have, it would be nice to have a backup plan. Like, how much longer are we going to work without a contract?
We do have a backup plan.
So, is there a deadline for Kaiser to, work it out at the national level?
Why would we do that when that would only harm us?
I don't understand. So
Why would we put an ultimatum to a 60 or $72 billion corporation?
It's not an ultimatum, it's a plan. Like, okay, so if
Yeah, but you just said to give them a date.
If we are like a year out from and if we are out like a year working without a contract, what's our plan B?
We wouldn't be a year out, because if you look at the times of where all the contracts land, they would all be expired at a certain date. And that is all public information. Perhaps the time would come that we pull the lever and have a different discussion. Now is not the time, because why would we do it when there's contracts not allowed to be opened?
What do you mean by that? I don't understand.
You can't strike if you have a contract that's not open. And within the alliance, we have contracts that are not open. And when their contracts expire are all public information.
So in other words, we need to wait for everybody to have an open contract and all go out together.
Correct. And that's honestly not that far away. And that information is public information that you can look up. I'm not going to share that information because I'm not going to have my name attached to that.
Yeah, it's just, I mean, it's just, I feel like we need to do the hard things, and no time is going to be perfect. But I understand where you're coming from. But it's just, from my point, it's like, what happened when UNAC walked out? And I thought we were an alliance. Why weren't we joining them?
I think those are good questions for UNAC.
Okay. All right. That's it. That's all I have. Thank you.
Anyone else? Final questions before we call it?
I have a question. Did UNAC have the ability to walk out when we walked out?
They did.
They were part of ours.
So the bigger question would be, why didn't they join us?
They did. They were with us.
In the first place.
They did.
Oh, did they?
Yeah, UFCW was the only one that didn't join us.
Oh, okay.
Anyone else? Any questions?
Oh, I do. I
All
saw
right,
something.
Shane, see what you got.
Sorry. We just took that big survey. Like what the membership would be willing to do. Did that come to fruition in any way that gave you guys a better idea of?
Yes. And that's why we're not walking anywhere.
Shit. Okay.
You know, I just have to say this. I think, I think it's sad and should be eye-opening. Why was only one position in our union contested? We don't have engagement. We don't have people willing. If they don't do a survey, then they're not going to walk out.
I never got the survey, and I looked everywhere for it. Just FYI. I think there was some chat stuff that people didn't get it. So I don't know what happens. But some of us didn't get it.
I can hear that. Recognize that there's always opportunities in there. We try our best to make sure everyone has it. We encourage folks that if they don't get it, to shoot an email to itsmyunion@openhp.org when those things do come up. But unfortunately, we're kind of past that at this point.
Yeah, absolutely. Not placing blame, but just saying that didn't receive
it's
it.
a barrier. Yeah, absolutely. Can the results of the survey be shared with us?
No.
I'm gonna say
why?
no.
Why would we share a survey that shows that we don't even have participation? Less than 30% of our Yeah, exactly what Elizabeth's saying. We don't want the results to get back to Kaiser. They're going to watch this video. They know. They watch you all. You don't think that they're not getting screenshots of the WhatsApp and all of these other things? They go. They know. They know.
They're not stupid. They have moles.
They have moles. We have lots of people married, managers and labor. We have people who, we're not ready. That's what we've been saying. And, maybe that's, that's just the nature of where we're at.
William Rutherford Baldwin. I actually thought that exact same thing when someone said mole. The guacamole, Austin Powers. Anyway. Chelsea Bruin. I'm going to screenshot that. All right. Well, if there's no more questions, let's call it. Thank you, everyone, so much for joining us. If questions or concerns pop up, please feel free to reach out. You have our contact information there. Remember, first line of information would be Katie Johnson that you'd want to email or reach out to for any and all things.
Yeah, even if you're not getting emails, because I know who to look you up with.
It's true. She's the queen of receipts, like I said.
Good night, everybody. Thank you.
Thank you, everyone.
Thank you guys for all your hard work.
Thanks.
Thank you, everyone. Thank you for your time. Thank you for showing up.
Thank you for showing up.
Does the recording just stop when I hit the button, or no? Do I have to upload it?
Because whatever you do, don't mess up.
I know, now I'm nervous.
Typically, when you end a meeting in Zoom, it'll automatically start converting the recording. So just don't
Go to
cancel
the
that
cloud?
box. Yeah.
Okay.
And
Okay.
it'll go to wherever you've set it up. Like for me,
I didn't
the
set it up.
recordings.
I can't be
Okay.
trusted. But somebody set it up, so I think it has to go to a cloud.
Okay,
Or
it'll either go to a cloud or maybe a server, or it should do one of those things. Just don't hit the cancel when it talks about converting the recording.
okay, don't hit cancel.
Yeah.
Okay.
Silly,
I'm
you
gonna-
end up with a lot of ones and zeros that make no sense.
Okay.
Billy, is your middle name Kent?
Stop trying to guess.
I don't know. I can't reveal this information. It could get back to Kaiser.
We already have it.
It's Kent, and if so, I would like to start a petition to have it changed to Rutherford. We can make buttons.
We only have a 30% engagement, so I don't think you're going to cross threshold, sir. Sorry, I know that hurt.
For real though, Billy, I like your idea of magnets or something like that. Would be really funny. Or we can do some sophomoric.
I mean, the idea I've had so far for the magnet board is we could have something about I applied the magnet over the patient's chest and now the people are pulseless.
That's pretty clever.
So
did you come up with that on your own?
I'm still spitballing this stuff, but you can be assured that memes will be crafted, and
I need them. I need you to send me those memes, please.
Yeah, it's the wee hours, and I'm going to be going back to work tomorrow with matches.
Well, at least you have hospital laundered surgical scrubs for a little bit longer.
We think, my guess is that those scrubs might have gone to the same place that our IV pumps and our people post results went.
Lovely, lovely. All right, everyone. Have a good night. I'm out. Catch you later. Thank you.